All right. So this is the fourth topic of the day, and we are going to look at the management of latent TB infection. So not everyone who is infected with TB develops active TB immediately. Some people would go for years and they would then have what we call reactivated TB later in life. This form of TB, where people are infected, but they do not have symptoms, they have this TB lying dormant in their lungs. This TB is not replicating, they are asymptomatic, is called latent TB infection. And this specific cause really focuses on why it's important for us to treat latent TB infection. In our traditional way of managing TB, we only focused on active TB, so people who present with symptoms and signs suggestive of TB, we would then provide treatment under that context. So we want to build a case that in order for us to end TB, reduce the number of cases, but also to reduce deaths associated with TB, not only do we need to treat active TB, but it is also important for us to identify high-risk populations who might be having latent TB infection and ensure that they get appropriate treatment. The treatment for latent TB infection is called TB preventative treatment, and it is the use of one or more TB drugs. This might include INH as a monotherapy, INH with rifampicin, which is what we are going to discuss today, but also rifampicin has also been identified as part of this group of treatments classified as TB preventative treatments. TPT is given to individuals who have latent TB infection to prevent the progression of latent TB infection to active TB disease. The treatment of latent TB infection would lead to the reduction in the overall burden mortality and also the cost of treating active TB. So this is a graphical presentation from studies that were done involving over 8,000 patients, and we are looking at the relative risk. So what is the risk of developing TB, for patients who are given TB preventative therapy, as an example, versus those who are not given TB preventative therapy. And specifically here, the studies looked at patients who were living with HIV and AIDS, where the tuberculin skin test was done and it was positive, right? And the results showed a 64% reduction in cases, in active TB cases for patients who received TB preventative therapy. Most of these studies also included isoniazid prophylaxis therapy. And I think the key message from this specific review of literature is that if you give TPT to high-risk populations who have latent TB, in this specific instance, there was a confirmation that these patients had a confirmed latent TB infection as evidenced by a positive TST. You get almost a 64 reduction in the number of new TB cases. So this was very significant, and we have known for years that the impact of TB preventative therapy is highest in people who have a confirmed latent TB infection as evidenced by the TSTs. Further studies went on to look into if we do provide TB preventative therapy in patients, regardless of their TST status, is there benefit? So that is the question we are trying to answer. Is there a benefit in giving TB preventative therapy in people who are at risk of getting TB. In this point in time, we are looking at people living with HIV and AIDS, regardless of the TST status, right? And the results showed us that there was a 33 reduction in the risk of developing active TB. This is quite significant, and this is what had actually led to the change in guidelines, specifically from the World Health Organization, but also the South African guidelines, to say, in terms of assessing eligibility to TB preventative therapy, well, we need to screen patients, and ensure that those with active TB are excluded from accessing TB preventative therapy, which is a tick. However, we no longer need to do a tuberculin skin test in terms of assessing eligibility, because we know that irrespective of your skin test results, there is still great benefit from giving high-risk populations, like people living with HIV and AIDS, TB preventative therapy. So what we know at this point is that, one, the greatest benefit of TB preventative therapy is with patients who have a positive tuberculin skin test result. That is the greatest benefit. However, all high-risk populations, irrespective of the TST results, have significant benefit from being initiated on TB preventative therapy. One of the bottlenecks in accessing TB preventative therapy was the concern, specifically from healthcare workers. I would specifically say my colleagues who are doctors generally would have a concern that giving INH monotherapy, or even 3-HPS is the case, would actually increase the risk or the number of cases of patients who develop TB resistance. So this is a meta-analysis of a huge list, of studies that were done. And we can confirm today that there is no evidence, right? Any suspicion or concern about the development of resistance once someone has been initiated on INH is unfounded. There is no evidence that actually confirms that INH monotherapy on a patient who was screened for TB and was identified as asymptomatic is a risk factor for developing TB resistance. Actually, in some of these studies, we actually had more confirmed resistance cases in the placebo group. So in the group that did not receive TB preventative therapy, actually helping us to understand that some of the patients who develop resistance would have had resistance even before starting, treatment. So we have a strong recommendation from the World Health Organization to say providing isoniazid prophylaxis therapy to people living with HIV and AIDS does not increase the risk of developing TB resistance. Therefore, all those concerns lack facts, they lack evidence, and we should start to ensure that every patient who's eligible for TPT actually receives it. If you look at how we have been managing and trying to control TB, there has been, a strong focus on treating active TB, and the implementation of some of our infection prevention and control tools, and then also looking at risk factors, especially the ones that we believed are modifiable and we can control. If you take any of these interventions individually, we are unlikely to actually achieve any significant impact on the burden of TB disease in our country and the world, right? Even the treatment of latent TB infection on its own would not get us to our end TB goals anytime soon. However, it is the combined effect of these interventions, especially where, as a country, we adopt that we need, one, to treat active cases, so it's a tick, But we also now need to shift our thinking and say we need to have processes and guidelines, which is what we are presenting, for timely identification of high-risk populations with latent TB and start to treat latent TB before they actually get to a stage where we say they have active TB. So we have to adopt the treatment of latent TB as part of the overall strategy for ending TB in South Africa. If you look at deaths, again, is the same. To say if you look at just treating active, that's why if you look at our deaths, we have not managed to put a dent, on our death, on our deaths. And the issue is we had an underlying thinking that says, well, we have almost everyone in South Africa has TB. There's that communication that we talk about on the sidelines. We say, everyone in South Africa has TB. Let's wait for them to get active TB, then we will treat. The unfortunate thing is that once people get active TB, there's a delayed diagnosis, and half the time they get complications of TB, which we have no control over. And we still, if you look at the treatment of active TB, we have not done, anything better than what we could. But now the evidence shows that treating both active TB and latent TB infection is the only way to approach elimination. So today we present to you and build a case that says we have a huge proportion of high-risk populations who have latent TB infection. We do not even need to confirm with a TST whether people have latent TB or not. The impact of giving TB preventative therapy, irrespective of a TST result, is very significant. And there is no evidence that giving monotherapy, INH monotherapy, or even 3HP, as is the case, would lead to an increase in TB resistance cases. And we appreciate that for us to achieve our end TB goals, we have to, in addition to other prevention and control mechanisms, now start to integrate the treatment of both active TB and latent TB. Thank you very much. I hope that you have managed to understand where the issue about the importance of treating latent TB comes from. At this point in time, I'm going to ask